Now, as we mark the 70th anniversary of the first successful human organ transplant, we're discussing how far we have come and what could be on the horizon. Renowned transplant surgeon and author of When Death Becomes Life, Dr. Joshua Mezrich, is here in studio with us with his expertise on where we are. Thanks for your time today.
Oh, it's fantastic to be here.
Well, it's our pleasure. I want to take us back. Let's go back 70 years to that first kidney transplant back to Boston, 1954. What was that like?
Well, it was really earth-shattering, and it didn't come out of nowhere. There were a bunch of people that were really trying to make transplant work. And in fact, at the Peter Bent Brigham Hospital in Boston, they were heavily invested in researching transplant. They actually started doing transplants in the late 1940s.
Okay.
They didn't really have immunosuppression, and the outcomes were horrible. And then this pair of twins came forward, one of whom had kidney failure, and it occurred to the primary doctor that maybe there was something that could be done, and they transferred the patients over to Boston, and Dr. Joe Murray ultimately performed the transplant. It was really dramatic. It was very stressful. They had no idea if it was going to work. They thought it should work. They actually did skin grafts between them to make sure that they were truly identical. They did fingerprinting at the police station.
Interesting.
To make sure they were identical, and then on that fateful morning, December 23rd, they moved forward and performed the transplant.
How much of that first initial success do you think was attributed to the fact that they were twins?
I think all of it. At that point, we really didn't understand immunosuppression, and all we really had were steroids and radiation, and no one really knew how much dose. In fact, they figured out radiation from the atomic bombs that were dropped in World War II, and they saw how immunosuppressed the victims that survived became. But they really didn't know how to dose it, and so in many ways, after transplant, the treatment was worse than their kidney disease.
Oh, wow.
So it took a while to figure out, but less time than you might think. A short 8 years from the first identical kidney transplant, they were able to do non-identicals and then ultimately deceased donor transplant. Not well, though.
That started somewhere, though.
It started. Yeah.
When you take a look back, though, at the techniques that were used then in 1954 and the medicine that was available and compare it to where we are today, was it archaic by comparison?
I mean, archaic is too strong a word.
Okay.
I think surgically, René Cousse, a French surgeon, urologist, performed the first kidney transplant more or less similarly to how we do it now. We have much better tools in the operating room, much better anesthesia.
Right.
So it's much simpler. But I think surgically it was quite similar for kidney transplant. I think for immunosuppression, it was unbelievably barbaric. They would just hit the people so heavily with immunosuppression to prevent rejection that they would get tons of infections and ultimately die from them. I think that refinement took a number of years with a lot of different people.
Interesting. All right, I want to talk about you professionally. What's your favorite organ to transplant?
It's like when you ask who's
your favorite child?
Right? I mean, I think every organ is beautiful. I think each organ has its own story, its own philosophy. I think like the kidney is the thinking man's organ. It does so much for the patients. The living donor kidney from a family member to a 30-year-old with kidney disease is one of the most beautiful things we do. I think the liver transplant is, to me, the most heroic. There were years where no one thought it could be done, and Tom Starzl and Roy Collin were really the two people who figured that out. But it's a massive operation. It used to be very, very bloody. We're better at it now. I think the heart transplant is maybe the most dramatic. When you release the clamps and the heart starts beating, who couldn't be amazed by that? But I will say, when a kidney starts squirting out urine on the table, it's a beautiful sight.
I think only the transplant surgeon would feel that way.
We always try to squirt the medical students.
Okay, their initiation.
That's their initiation. Who wouldn't love that?
Right. You have said in the past that transplant surgeons face a lot of tough calls. What do you mean by that, and what are some of those tough calls?
You know, I'm amazed by how many decisions you have to make in the care of any patient or in selecting an organ. They are just constantly decisions to be made, and some of them maybe ultimately don't matter. Probably a small percentage do, but you don't know which of those that do. I think some of the hardest, first selecting an organ, is this the right organ for the patient? It's never perfect, and someone's just died, they've gone through something. There's always going to be challenges with that organ that could lead it to not function well. And then I think every patient's different. By far the hardest thing in our job, in my opinion, is dealing with complications. And I think that even though most of our patients do great, we spend all our time thinking about those patients that have complications. And I think trying to stay with the patient and manage them through that with all the decisions you have to make and seeing the suffering the patients might be going through is the most difficult, but sometimes can be where you develop the closest connection. Can be so rewarding when you help someone get through a complicated course. But I think at the end of each transplant, I think about the millions of decisions we've made, and I feel really proud of it, that our whole community has figured this out.
Are those, in the event of a complication, which obviously that's the last thing that you want, but sometimes it happens, that's life. Yes. Is that something you take personally?
Yeah, you really do. I mean, there's something about surgery that it's very invasive, and you take a patient and they put their lives in your hands, and you can't control everything. We all try to be perfect, and we can't be perfect. But I think when something doesn't go right, it feels very personal. And whether you feel in retrospect, I did everything the way I wanted to, I would do it all the same again, and that's sometimes the case. Or sometimes you're like, oh, I wish I hadn't done that. I really regret that. Those can be very difficult to live with. But for me, the way I've dealt with that is to be very honest with the patient, to tell them, I'm sorry you're going through this, but I'm going to be with you every step of the way, and any questions you have, I will answer. And then relying on my partners to help me with that. But it's very personal. You feel very responsible. And those things can sit on you in a tough way.
Right. You have also really, over the course of your career, prioritized the donor's family. Why is that important to you?
I think that's the most important thing. And when I was thinking about writing the book, one of the most important parts was to make sure people understood that the donors are our heroes, and the deceased donors, to me, are our patients. They're absolutely our patients. And I don't think anyone should ever look at them as, oh, there's just this source of organs. That's not right. I think that they're giving this last beautiful gift, and although they won't live to see it, their legacy will be what their family sees. And it really says something about the beauty of who that person is, regardless of what they did in their life, that they're willing to bestow this gift. And so I never want to say, we need to get more organs out of this donor for my patients. I always want to say, we want to help honor this gift and help let this donor give this beautiful gift that's going to sustain life. And maybe their family members will listen to their beating heart in someone's chest, or we'll meet with a recipient who is able to live their life because they have their pancreas or their lungs or their kidney. It's all so beautiful and special, and it's the most important thing we do. Yeah,
the gift of life. I want to talk about a hot topic in transplantation right now, and that is xenotransplantation. Your thoughts? Are there ethical concerns? Is this the way forward?
Well, so I am a xeno-optimist. I'm a lover of all things xeno.
Okay.
I first was exposed to it when I was in David Sachs's lab back in '99, and I believe in xeno. I think it's really, really hard. So I think we've advanced massively from the early days of xeno with gene editing, with understanding immunosuppressive protocols. And we now have unbelievable results in primates, so pig organs genetically modified into primates. Years of survival with kidney, with heart. The human transition is going to be very difficult. Of course, there have been 4 humans now, 2 heart recipients and 2 kidney recipients. And although initially the organs worked beautifully, 3 of those patients have died and 1 had the kidney removed. It's disappointing, but at the same time, we've learned so much, and the organs did perform beautifully out the gate. How is this going to play out? It's really hard to answer. I do think back in history and think, although they had those early successes, they had so many failures, and it took years to figure out the right doses, the right patients. We're in a different time now. Back then, the patients would die if they didn't get transplanted. Now we have human transplantation, we have long-term dialysis, we have mechanical support for heart patients. So I don't think we're in a position where we can take exactly the kind of risks people took back then. But I still believe that ethically this can be advanced, and that over the next decade, we're really going to figure this out and start getting year survivors out of these organs. But
that's soon. You think we'll see significant progress in the next decade?
I mean, I hope so. There's been this traditional quote that I believe Norm Shumway is attributed, he's the father of heart transplant, where he said that the future of transplantation is xenotransplantation, and it will always be the future of transplantation. And I believe we will put that quote to bed. I think we've advanced so much, but there's a lot of unpredictability to all of this, and I'm a believer, but we have to make sure we proceed in a very ethical way where the patients know exactly what they're getting and where we really believe this is the best choice for them medically. And that's going to take some real thinking to do that right.
All right, before I let you go, since we are talking about 70 years, of successful transplantation, can you finish this sentence for me? With regard to transplantation, I think in the next 70 years we will see.
I think we will see transplant being a totally different field. So right now, it's a field for end-stage organ disease for really a small number of patients. We have 100,000 patients on the kidney transplant wait list, and that's a big number. But there's over 1 million patients that are on dialysis. I think our heart transplant list is a few thousand patients, but there's 6 million patients with heart failure. And I think once we can separate the organ supply from someone having to die or a living donor stepping forward, we can start looking at transplant differently, where really patients that are struggling with organ dysfunction can look at transplant as a way to live longer and better in a totally different paradigm. And I have to give Dr. Bob Montgomery credit. He's probably the one who really talked about this idea of a different paradigm, but I believe in it. The other area where I think we're going to get better and better at protecting and improving organs that are dysfunctional, whether it's reducing NASH, we've already gotten rid of hepatitis C, figuring out how to avoid type 2 diabetes leading to renal failure. My hope is that we can also reduce those patients that need these transplants.
I know I said that was the last question, but actually you bring me to another point. With some of the tough calls that transplant surgeons grapple with, how do you make the call or make the decision about maybe giving an organ to somebody who might be struggling with some sort of a drug or alcohol addiction?
I mean, it's such an important topic, and alcohol is the number one reason right now for liver transplant. I think I need to remind everyone knows alcoholism is a disease, and it's a mean disease, and it's a disease that's hard to treat and that recurs like any other disease. And while transplant doesn't necessarily cure that disease, it can rescue someone who's suffering from a liver failure, who then can, get their life back. I think almost all diseases we deal with, other than maybe the pediatric population, are diseases of attrition or diseases that happen because of some part environment, some part genetics, some part bad luck. And I really try to avoid judging a patient saying, oh, you got this disease, you did this to yourself. Because the truth is, if we didn't drink, if we didn't smoke, if we didn't use drugs, if we drove more carefully, if no one smoked, we probably wouldn't.
You'd be out of business.
But we're all humans, and we all walk in different shoes, and we live our lives. And I think having compassion and saying, rather than saying you did this to yourself, saying, can we get a good outcome? Can we get you back to a good life? Do you have support? Do you have insight? Are you committed to this? And if so, I think it's a life worth saving.
Wonderful. Well, thank you so much for your time today. Certainly appreciate it, and for all your insights.
My pleasure.